So our second case here is a gentleman who is very symptomatic at presentation with weight loss, decrease in appetite, and has a number of the classic features that are associated with this disease. So he's symptomatic, he has venous thromboembolic complications which occur in a proportion of people with pancreas cancer at presentation. And he has a reasonable performance status, but his albumin level is low and his disease burden sounds high, and this is a person that you sort of worry about, that they're on that progressive downward trajectory and need to get started on treatment sooner rather than later to stabilize their disease and hopefully improve their symptoms and extend life. So this gentleman went on to receive a standard of care with gemcitabine nab-paclitaxel, had disease control for about 4 months, which is plus minus average in that range, and then went on to receive a second-line therapy. His performance status at the time of initiation of second-line therapy sounds like KPS of 70%, so again on the decline in terms of well-being. And liposomal irinotecan, 5-FU, and leucovorin, as we discussed in the other setting, has been evaluated in comparison to 5-FU and leucovorin and in comparison to irinotecan, and was demonstrated to have a survival advantage. I think it's important to acknowledge here that liposomal irinotecan on its own was not superior to 5-FU and leucovorin, and that's not a recommended approach in this setting. So certainly for a patient that's well enough, it is logical to consider the treatment strategy that was undertaken here of liposomal irinotecan following gemcitabine-based therapy. That's the exact setting where this drug received its approval. And we'll just expand on that a little bit and say that it was in a previously treated gemcitabine setting, so that could be gemcitabine given, as was here, in a frontline treatment for metastatic disease. It could be gemcitabine given in a neoadjuvant setting, or even gemcitabine given in a postoperative adjuvant setting, and then on development of metastatic disease linking into this regimen. So with regard to the NCCN guidelines, these have evolved to reflect the fact that there are now more choices both upfront with the 2 major regimens that we've spoken about, but also that other gemcitabine-based combinations may have utility. For example, patients with a less favorable performance status as initial treatment. Gemcitabine capecitabine might be considered for individuals with a genetic underpinning to their cancer, for example, a BRCA mutation. It's an accepted consideration to use a platinum-based treatment. So in addition to FOLFIRINOX, cisplatin and gemcitabine, or even FOLFOX might be an option for that individual. And for patients who have a distinctly less good performance status, initial therapy, single-agent treatment with gemcitabine represents an appropriate choice. So they would be frontline. So again, respecting what was given frontline will influence what would be the consideration second line. So 5-FU-based therapy frontline, gemcitabine second line, gemcitabine nab-paclitaxel frontline, liposomal irinotecan, 5-FU, logical second line, and then oxaliplatin-based therapies if a third-line treatment is appropriate. And all the time, I think, being mindful as we treat these patients, is there a clinical trial consideration? Is that a suitable option? Is it a logistic option? Is it an option that the patient and family are interested in? Because that's ultimately going to have the biggest impact in terms of additional choices for these patients as we move forward with treatment for this disease.